Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, we have a shoulder symposium involving world-renowned shoulder experts. Dr. Anup Shah from San Antonio, Texas, Dr. Paul Sethi from Connecticut, Dr. Anand Murthy from Baltimore, and Dr. Joseph About from Rothmans, Philadelphia. So let me introduce you to the first speaker is Dr. Paul Sethi. Dr. Sethi is a clinical associate professor at the Yale University School of Medicine and president of the ONS Foundation for Research and Education at Connecticut. After completing his residency in the Yale UVA1 Hospital, he completed shoulder fellowship with the Curlin Job Orthopedic Institutes in Los Angeles, California. He's an elite member of the ACS Near Circle, and he's also the program chairman of the ACS Residence course. He's been in the AOS Public Relations Committee during 2011 to 13, and currently serves as the AOS Shoulder and Elbow Content Committee. So over to you, Paul.
Thank you very much. I'm glad to be back on Orthopedic Principles, and we've got a great team here. What you'll hear now is a short talk, 10 tips in 10 minutes on arthroscopic surgery, followed by case presentations from myself and my colleagues that you previously introduced. Here you can see a CAT scan of someone I was seeing in the emergency room for an irreducible dislocation. As you can see, this is a type C glenoid and not such a tricky reduction, or reduction not required. By this way of disclosures, I do work with Arthritis and Posterior, and I am on the board of the editorial group of the Shoulder and Elbow Journal. None of these are going to be an issue for me today. I want to take a minute to have two plugs. One for our organization, the IASES, the Indian American Shoulder and Elbow Surgeons. This is a young group formed, and the goal of our group is to increase the interaction is the Shoulder 360 course. This is really the new biggest course in orthopedics. This will be in April of 2022 in Miami, so it's easy to get to, and I hope that would be really good for traveling. And we're going to have over 40 world-renowned faculty, so please put these on your list as things to do next year. Jumping into it, I want to acknowledge all of our faculty. Hitesh, what you've set up is quite amazing on this site. The Sultan of Orthopedics that we can see right here, dead center. Anup Shah, who's now in Phoenix, Arizona, to be more specific. And Joe Booty's telling us something here, and I have a feeling he'll be opening his mouth and talking a lot towards the end of this. Anyhow, let's go on. Proper indications. Here's my 10 tips. Let's get after it. I think the first most important tip is identify and indicate instability in an ideal fashion. You know, certainly we're all going to see revisions here. We can see one from San Antonio, but why did this person fail? What is the problem? What were the patient factors? Was it technical, or was there something anatomic? So identifying the substrate, not just my shoulder comes in and out, doctor, but what's going to happen, why they might have surgery, why they might fail surgery, and identifying these things in advance is the first important tip. There are there's a lot of different ways, and actually on this slide we should now include the idea of a engagement score, or an on-track or an off-track score. But initially the instability, the ISIS score came out, and this had an unfortunate timing with publication and the rise of the actual ISIS. But as it turns out, look, this had a lot of value in helping us to understand significant risk factors, whether it was age, collision, sport, their individual clinical hypermobility. I don't know that this exact score turned out to be a guide, because it really pushes a lot of at least North American athletes into ladder J, which may not be necessary, but nonetheless keeps your brain on track. Using as well the on-track and off-track score, I think in conjunction can help get you a gestalt or a concept of what might or might not be required. So identifying bone loss, look, this is critical. And unfortunately, Burkhart and De Beers let us know about this just about 15 years ago, but you just got to have a high index of suspicion, particularly when there have been multiple episodes, when there's an ease of instability. And I mean ease of instability means that it comes out in your sleep. It comes out with just gently lifting your arm up over your head. Instability and bone loss is more common than not. We see in military studies early loss with a single dislocation of 5 to 10% bone loss. And if there's any question, if you and your brain, it's a little bit like a patient who comes in with calf pain, there's no doubt you're going to get an ultrasound. When you have any question in your mind of bone loss, I think you should get advanced imaging. And I specifically mean a CAT scan. And I prefer a 3-dimensional CAT scan to really help me most accurately measure bone loss. On your exam, look, you want to understand the difference between laxity and instability. There are patients who are going to be hyperlax, and I think you want to think differently, at least slightly differently, about the hyperlax patient. The hyperlax patient who has pain from instability is one thing. The hyperlax patient who's actually dislocating in a collision sport presents a greater challenge because they're not just going to be a routine bank card, at least not in my hands. So enough of the before. Let's get to the operating room. You want to set up the case. What position should you put the patient in? You could put the patient in any position you want, but the bottom line is that lateral is going to be better. Lateral is going to allow you to see the posterior labrum.
I think prone might be hard. I think prone might be a little hard.
Prone, no, yeah, you know, I'll agree. Dr. Murthy, your original paper on the prone instability repair has not really panned out, but yes.
I'll mute myself.
I'm trying to do it myself and it's not working. Look, examination under anesthesia. This is going to be, and you guys should throw some darts at this. In my opinion, and I've been saying this for a long time, I think the EUA matters, right? So here we have 2 cases where you've got bony Bankarts, acute or subacute. And in this case, you can see the EUA. Oh gosh, EUA sideways here. But comes in, comes out, comes in, comes out. The person's got normal instability. In this case here, the EUA, let's play correctly. All right, I got lucky here.
And go live on. Yep.
You can see locks out, stays out. Boom, comes in. Locks out, stays out. I think that grade 3 is a little more common than we think. And for me, at least in my hands, a grade 3 EUA is going to suggest I need to do something more than a simple arthroscopic 3 or 4 anchors up the front. There's something greater about the pathology there.
Bobby never let you examine my shoulder under anesthesia.
Joe, I believe that the one on the left was you that I had there.
He likes to make ladder J's happen, Joe.
Wow.
Portals, so you can gain access. I think that going trans-subscapularis, especially with some of the new anchors, can help you get down low enough, and some of the curved devices to really come in percutaneous. So I don't put a portal through the subscapularis. If anything, I'll put an anchor or an anchor device through that. But you can come at this any which way you need to gain the appropriate access. More important is not to skive, particularly when coming in through the back. I think you can sometimes get tricked into being a little lazy that, oh gosh, I can get this anchor in through the posterior portal, and really you run the risk of getting subchondral and doing articular cartilage damage that will later manifest in the 17 or 20 years old life. So you can see the spinal needle and the trajectory of the spinal needle relative to the cannula coming in through the back there, and I think that's important for getting into the subchondral bone. Again, similarly, posteriorly, you want to come in. You want to come at an angle. I think it's also important in avoiding complications not to have too many little drill holes that are going to line up and set you up for a postage stamp fracture. So as perpendicular to the glenoid face as you can be, especially low down, is important. So letting you know or emphasizing the position of your lower anchors. You don't want to set up sort of a small set of drill holes that will later end up as an osteotomy or a risk for developing a fracture. Look from before, from the front, from the back. You want to find that you're not stuck in the posterior portal the entire case. I think that's a mistake. It's the same sort of parallel mistake that some people will make in rotator cuff surgery by only looking through the posterior portal through the whole case. You want to get different views and different mobilizations and localizations of your case. You really want to be able to retension this ligament, and you want to be able to grasp from anterior, inferior, anterior, posterior. So here's just an example arthroscopically. Look at the labrum. It's stuck down medially. It's not floating up freely. I'm starting to mobilize it, liberate it, whichever terminology we want to use. I'll switch over to a sharper tool, and I'll continue to peel this away. And again, it's starting to float up a little more, but not where I want. I want to see subscapularis fibers. I'm looking from posterior initially, but I will switch over to looking from anterior in just a moment. Continuing to sort of really work at this, come around, identify. Now you see I switched to anterior. It's the same case, but I need to really come around. And at the same time as I am mobilizing this, I'm starting to prepare and scrape away some of that anterior glenoid bone. I want to get some tissue healing potential there. So once I fully mobilize this, I really come all the way around. I can look down. I'm going to try and prepare it. In a chronic case, I'll use a burr. In acute case, I might just use a rasp, but I want to have it. But you see, that's where I started, and boom, it floats up. Now, when the labrum floats up, that's when I've done adequate mobilization. A trick I learned from Sanjay Desai is to use an open curette right on the edge there. That can help me get some of this loose articular cartilage and really prepare it as best as I can. If you need to come all the way around the back, you can do that from anterior superior just the same. So you can really get a lot done. I want a tension. So this is important. I'm going to grab the tissue, pull it, and tension it up. And when I grab the tissue and pull it and tension it up, then I can pass my stitch. So I'm getting a shift done. It's, once again, an important tip. Get your shift done. And then here, I'm going to use a knotted anchor. I'm going to work my way through. And this is the hardest part of the case. And in this case, this is a knotted anchor. I'll show you an example of a knotless, but really getting it down, getting a good bite of tissue, getting a good suture put into place. There are lots of ways you can capture the tissue with simple cinch or tape stitches. A way that I've been doing it lately is with a knotless device. And here I'll pass the knotless device, and before I tension it, once again, the same concept, I'll grab the tissue and tension it all the way. And then I can pull this knotless device into place, capturing my tissue and really shifting it very nicely. What I like about these knotless devices that I admittedly didn't like before, they're very small, they're all suture, and you can probably put 4 or 5 up the face. And I think the reduced real estate, reduced hole is probably nice in these younger patients. Here's just another example of using tapes and pound-in anchors, which is another very common thing I'll do. But again, I tend to use the more knotless now. You can get down really low in a lot of ways. You can optimize your anterolateral portal. You can come in percutaneously. You come in percutaneously and dilate over a percutaneous, or more importantly now, I think a lot of these curved delivery devices. So here I am, I want to get down really around 6 o'clock. This is a multi-directional case that I want to really maximize on. So I'm placing a spinal needle in. I'll dilate over the spinal needle. I'll show you the intra-articular view in a second, but this can be useful, especially with dealing with some harder fractures that go way down medially that you want to capture arthroscopically. There's nothing wrong with doing this case open that I'm showing you with the CAT scan, but nonetheless, I think there are ways to get lower into the inferior aspect of the glenoid. And again, percutaneous can be helpful. So now that you see me sort of dilating on the outside of the skin, I'll poke into the intra-articular view right over here and show you what that looks like. In the same way, but this can be done anteriorly. So look here, you can see I'm really coming in as close to 6 o'clock as I can. And I think now I'd use an even smaller drill with an all knotless anchor, so that I'm affecting less real estate of the bone. Posterior inferior suture and anterior instability. You know, sometimes the anatomy makes it easy. The tear drifts around to 7 o'clock, and it's obvious that you do require an anchor there. But for me, a collision athlete, a 17 to 20-year-old, they're going to get a posterior suture inferior anchor. I learned this from Tony Romeo many years ago, and I have not had issues with over tightening or loss of range of motion with the routine added posterior inferior suture anchor. And in commonplace, I'll put that anchor in place. I'll capture the PIGHL, pass it through, shuttle it out in a second, but then I won't fully tighten it. So now it's sort of almost ready to go. Well, I have one more step of shuttling here, but it'll be almost ready to go without fully tightening. And if it's not fully tightened, it doesn't box me out or injure me or bother me when I'm trying to get what I want. So now you'll see, I'll snug it up right before I get to the point of tensioning. And when you see these little twists in the suture, I think it's always best to reach in and pull them out just so that you can maximally or most accurately tighten and not get any kind of jam in your anchor. But I'll leave it like that. I won't get much more. I'll leave it like that. Then I'll go back to the front. I'll finish my front, and then I'll come back and get the back at the very end. Last 2 points, sorry. Respect the ALPSA. ALPSA tears are different. They're different animals. They reflect different tissue quality, and the rate of failure is going to be higher. We don't really talk about it a lot, but But Bill Levine and JP Warner both discussed their series. And when they looked at their own individual ALPSs, they had failure rates of closer to 25%. Even the tissue and the tissue quality, once you get the ALPSa repaired, and you really see, you really can sort of get it. And this is another way to get the edge of that articular cartilage. Now I like that open curette along here. It can be really, really sort of elegant instead of multiple steps to do it. But even when you repair that ALPSa tissue back up, it's just not the same quality tissue, the same integrity. You know, it looks good as you get it up there, but it's not quite the same. So just have respect for that ALPSa tissue. Engaging Hill-Sachs lesions, there are times you're going to get into the case and you'll see that hopefully you'll pre-identify this on a preoperative x-ray. You'll see it and an MRI nonetheless, and you'll maybe identify that this is a person at risk. There are times when you're going to want to consider a remplissage as one of your possible solutions. And here, just coming in from posterior, I'm going to place more lateral than my cannula. I'm going to place anchors in, and there's lots of ways to do this remplissage. You can do it knotless. And I'll go ahead and repair my anterior. For arthroscopy, Joe, Anand, Anup, any quick tips on arthroscopy before I go into the case?
Well, I wouldn't use so many metal anchors like you did on this case. So that's probably not a good thing to do. But other than that, I think the ALPSa lesion really needs to be discussed more, because it's just, if you think about it, it's chronic. There's probably some bone loss. The tissue's poor. It's probably some bipolar lesion to it. And just doing a simple Bankart scope is probably not enough.
Joe, you're about to say something.
You know, I think of the common orthopedic arthroscopic procedures we do around the shoulder. This is the most technically demanding and important for meticulous technique, because I think it's the highest cause of iatrogenic premature post-traumatic OA caused by us as surgeons doing bad surgery. And while you do need to adequately reduce things, sometimes less is more. You know, be careful of the balance between fixing the tissue and putting in so many anchors that the arm doesn't move anymore, so it's so stiff and arthritic. They go from 23 and stable now to 35 and massively arthritic. And those are our patients that we're doing these anatomics on prematurely.
I mean, Joe, I think you have a lot of wisdom in that statement, because most of us think that, gosh, an arthroscopic anterior Bankart's relatively easy, much easier than an open shift, much easier than a complex cuff where I have to do the reduction. But you're absolutely right. I think that we don't necessarily think about this patient 10 and 15 years later because they don't always come back to us. And Anup, your one pearl on arthroscopic instability?
I thought you did a great job, Paul. I would just say from a technique standpoint, I agree with everyone's comments, but from a technique standpoint, you know, additional portals will always help. Something I've learned, and that's helped me once in a while, especially if I'm struggling to see or I just need an extra set of tools to get in, is a superior portal through the medial to the rotator cuff cable. So it's just through the muscle. And it's essentially like a 50-yard line view that we use for the cuff laterally. And you can really see from front to back and utilize portals and place anchors from front to back as necessary.
That's very French of you to say that, and I appreciate that that portal. All right, so I'm going to present one case, and then I'm going to hand it over to my colleague. This is a 45-year-old man, okay, and he's had a long 15-year history of subluxations. He doesn't feel his shoulder, frankly, dislocating. And, you know, given this long history, it really is low demand. He's not looking for a lot. He wants to play tennis. He wants to walk. He's got no real medical history with respect to blood pressure. He's had one clavicle operation where he broke his clavicle, and he's actually just gotten frustrated. He feels like his shoulder's just not stable and he can't do a lot. His x-rays are, I'm going to show you, his x-rays are right here. He's got this plate placed from his clavicle. He's got a pretty normal looking joint space. He doesn't have anything suspicious on this reasonable axillary film. I got an MRI and I actually got an arthrogram on him because he hadn't been dislocating, and I want to get a better sense. And what was surprising to me, or was interesting to me on this, he didn't really have any significant bone loss. So my threshold for getting a CAT scan, well, I was worried about this guy because he has a history. I thought to myself, well, let me start with an MRI. But as I looked at his axial cuts in particular, I thought he had no labrum at all. Really, very, very deficient. And if anything, I could see maybe a small flicker of anterior labrum right over there. Really far scar medially. So, an ALPSA, but to me, this is a bad ALPSA or a very chronic ALPSA. I don't know, Anand or Joe, or you two first, you have any comments on this guy's films? Are you compelled to get a CAT scan on this guy, or what are you going to do?
I'm a little worried about his cuff. At least, I don't know if you're leading us down that path, but if you look at that coronal, it looks like he may have some like articular sided avulsion or liftoff there. But I agree with your assessment of the labrum. Looks pretty blunted.
Joe, you getting a CAT scan on this guy?
When I look at the MRI, I see a little inferior osteophyte on the coronal and some squaring off of his head a little bit on the coronal. And on the inferior sagittal glenoid, is that some small cyst formation on the glenoid. So this is a guy that I'm thinking he might have some early OA findings.
Yeah, fair. So look, here's his EUA, right? Because to Joe's point, could he be faking us out and telling me he has instability? And actually, he is really very, very loose on EUA. So let's just jump right to what I saw at his arthroscopic findings, because we still have the ability, since I did him prone on it, we have the ability to change him to whatever position we want. I did not, just anyone who's listening, he's in the lateral position. He's not prone. So here's his findings at arthroscopy. His joint actually looks pretty good. He's got a reasonable Hill-Sachs lesion. And then I go to look for his anterior labrum, and as expected, he's got really not much. It's very grossly blunted and poor quality tissue. So Anup, 45 years old, you have everything you want in the room. You have a hemi, you have a reverse, because I know you're going to channel your JP Warner experience with that. You also have arthroscopy equipment. You've consented him for ladder J. You have a distal tibial allograft. You have his clavicle. You have a Glenojet, and you have every anchor from Arthrex, Mytech, and Stryker available. What are you going to do for this guy?
Only in Greenwich, Connecticut can you do that.
Yes, that's right. But I don't want you to feel limited by, so you have his images, you have his EUA, and you have his arthroscopic findings.
So this is a tough case. I think for me, it really boils down to the conversation I had with the patient preoperatively. So what are the patient's expectations? Certainly you don't want to put in an implant, for example, if that conversation has not been had. And so I would say, if my conversation with the patient was, basically we're going to do whatever we can to fix you, and this includes A, B, C, D, then I would probably consider in a 45-year-old a ladder J. I think, especially since it's a grade 3, it engages based off your examination under anesthesia and examining this arthroscopically if it engages. My preference would be to do a ladder J and a patient like this with a joint that looks this good.
Anand, what would you have done?
For a 45-year-old who's never had a locked out dislocation, if I'm correct, he has what looks like an off-track Hill-Sachs. I would do a capsular shift, remplissage.
Arthroscopic, open?
Arthroscopic, yeah.
Joe, final word?
Pretty powerful for him.
Yeah, I would do what Anand just said.
Yeah, so to me, the mitigating factors that he was 45 and that he was not, he's low demand and not experiencing instability. So what I did actually is I pulled a graft in. I made a hamstring graft. I could have used his biceps, which I thought about, and I created a labral graft. And affixed it inferiorly. First I fixed it inferiorly, then I fixed it superiorly. And I used double loaded anchors to affix it. So each of the anchors then were used to grab his native capsule and really sort of try and shore up or firm up his native capsule. In addition, he did get a remplissage. And honestly, he's about 3.5 months out. And maybe if I didn't do the anterior anterior tissue, he wouldn't need it. But I think that there is some ability to sort of hold or strengthen that anterior repair. So it's definitely an outside indication for.
Did you mobilize the capsule like a regular bank cart still?
Yes, I mobilized it as best as I could, but I thought it was really lousy, right? So then by putting this bumper into, I'm grabbing the normal native ALPSA and augmenting it really with this. I know creating a bumper isn't really the goal of what I was trying to do. He'll roll right over any bumper with no capsule, but a different type of solution for this. So we'll see, guys. I don't know. Jojo, you want to beat up on it?
No, I mean, I like it. Definitely nothing I've ever thought of. I usually, in cases like this, will grab some of that sort of posterior subscap tissue and kind of incorporate it into my capsular reconstruction to give me some sort of capsule for the shoulder. I haven't done this. It's pretty interesting.
And I totally agree. I just worry so much about a post-traumatic arthrosis with grabbing the subscap. A la Magnuson stack, but yes, I've done that a lot.
The remplissage is very powerful. People think about it makes it extra articular, but it really is a check rein of your shoulder going anteriorly. And if you put a couple double loadeds and really tension the remplissage in a 45-year-old, who's got really less elastic tissue, it should work pretty well.
And fair, if this case works, I'll never know if the remplissage alone would have been good enough, and I may be sort of confident for no reason. Once again, to plug the Indian American Shoulder and Elbow Society, this is an important new group that will be again at the ASES. And once again, to plug Shoulder 360, this is the shoulder course, April 2022. With that, I want to hand this over to Dr. Murthy, followed by Dr. Shah, followed by Dr. Abood. This is Drs. Murthy and Shah discussing the future of shoulder surgery in Laguna Beach.
Is this, can you guys see my screen? Can you guys see the screen?
Yes, Anand.
Yeah.
Great, perfect. So I'm going to talk a little bit about open stabilization. A couple things Paul wanted me to talk about. I'm probably the oldest doc on this panel, so I've done probably more of these over my career time, including training. So this is a 21-year-old male. What's that?
You are the oldest by a lot.
Oh, by a lot. Okay. We'll talk about that later. 20-year-old male, American football player. He's had 4 dislocations requiring reduction. His season is over. On his exam, he has no atrophy, no outliers, no hyperlaxity. His motion is very good. But, for me, a very positive apprehension relocation test is very pathognomonic for anterior instability, and he has a strong cuff as well. This is the Gagey test for hyperlaxity, and I use this and teach our trainees this as well. Looking for hyperlaxity versus pathologic laxity, and not missing a potential MDI type of patient as well. Standard imaging, you can see there's no bone loss. What do you think about imaging, Joe? Jump out at you?
Very suspicious of significant bone loss, then an MRI is fine. But if it's a tweener and I'm trying to decide if I need to do a bone block, then I'm getting a CT with 3D recons.
What do you think about this patient? ALPS lesion, perhaps, or just a labral tear, just a bank heart?
Looks like
this reminds me of my case, Joe.
And
this labrum, centimeter medial to the glenoid. Look, you can release them. Yeah, you can find them. I just don't know that you ever get them back to being normal tissue to hold stability.
When I see this on a axial MRI, I get really worried about being able to do a standard bank heart labral repair. So what we can talk about is, what are the indications? It's a football player, linebacker. What are our concerns and morbidity? So would you approach this guy arthroscopic, open, Latarjet, distal tibia? What do you think?
I'd probably approach this arthroscopically if there's no bone loss, especially given how young he is, with the understanding that depending on the tissue, the quality, and so forth, that he may have a higher recurrence rate, just given, he's a male contact athlete, all the things that Paul alluded to in his slide.
Joe?
Yeah, I would agree with that.
I would say that since the top of the slide says open stabilization, I have a feeling that you're gonna look. But all kidding aside, I think if this is a collision athlete with a labrum that looks like that, he's going to be that 20% that recur. I mean, I have no hesitation now. Now, maybe we can get to the longer debate is there any role for open surgery on, and should you just go to is it ladder J or scope, and is there nothing in between? And
Right.
Romeo in a meta-analysis says that, but I'd like to, you'd like to sort that out.
If you were going to do open, how would you approach it?
I would do, an open problem. If he's hyperlax in grade 3, I might take his subscap down. I don't really worry about subscapularis healing if you can heal it, if you can put it together well in a 20-year-old. But if he's just if he's more grade 2 and has this, I think he can be a subscap split. I think you're allowed to have some bandwidth in deciding what effect you're looking for.
I think one thing to remember on these athletes is that they don't have a second chance, really. And even the one chance to go pro when these guys have open any kind of stabilization surgery, many of them are weeded out by the combine and can't get into the NFL. So you have to make sure that they don't lose another season or 2 years from something that fails, and try to give them their best one shot at it. So I'm going to go through some of the technical aspects and then some video. So we can do it through in a small incision. The goal is this utilitarian approach, the open capsular shift, described by Neer and Biliani, is to take and separate your subscapularis from the underlying capsule. And that's probably the most difficult part to do. We work from the muscular layer up, we put traction stitches, and then you can see the underlying capsule. And we're going to use the capsule to do all of our repair. Now we take the capsule down in a second layer, leaving stumps laterally as well. And our goal is to take all of this capsular laxity in the inferior pouch out of play and shift that up so they don't have any redundancy to dislocate anterior inferiorly. And then you can titrate how much capsule you want to shift per patient by either splitting, creating a T, or just bringing everything inferiorly, superiorly. And then obviously you can work on the bone and reattach the capsule. We're not reattaching labrum, we're actually reattaching the capsule medially down to bone. So this is our standard approach through a small incision in the axilla. You can split the subscap. You can take down just part of the subscap. I take down the subscap routinely. You can take a little bit of the pec, especially in these muscular males. So this is a left shoulder. We're leaving a stump laterally, and you can see that we are carefully separating the subscap off the capsule. Different devices, Kittners are starting in the muscular layer. Release the interval until you have complete separation. And the pearl here is you have to be able to palpate the glenoid. And now we've got retractors deep to the subscap, and we're going to carefully release our capsule from the lateral humerus. And we'll keep releasing inferiorly until we release all these folds that go to the humerus inferiorly. So then we pull on those capsular stitches, the entire pouch is gone. So now we've taken our capsule down. We're looking at our Bankart lesion. Standard anchors, make sure they're up on the rim at least 1 millimeter. And then you're going to go inside out with those sutures to make sure that you repair your Bankart lesion back down to bone, and your capsule back down to bone. If there's still some laxity after you've passed those sutures in an inside out fashion, you can do what's called a barrel stitch, which is an outside in, inside out inferiorly stitch, which will then crimp your capsule in the anterior inferior margin. And that's called a barrel stitch. So we're going outside in superiorly at around 2 o'clock, inside out around 5 o'clock, and then we'll tie that on the outside part of the capsule. So release the capsule, identify your bone, anchors on the rim, and you can see when you're done, this is a sheet of capsule that has been repaired to the glenoid, and that's a great result. And most people will have a very low recurrence rate. standard recovery. We protect the subscap and get them back to high level football. So he got back, and he's actually playing a senior year in college now. So he's doing very well. So these are kind of the ideal cohort. Any comments on open stabilization, Paul?
I just think it's an important, look, you don't, if you have no bone loss, you've got an Alps lesion, or you've got a failed case that's had previous well-done arthroscopy. I don't know that you need to go to Latarjet right away. I mean, I like the Latarjet. I use it a lot. It's a great operation, but it's non-anatomic. It's got its own issues with hardware issues. It's got its own issues with nerve injuries, and it's got its own issues with later, doing shoulder replacement on those who have had bony procedures 15, 20 years ago is not simple and at higher risk. So I think that there's an important place for this in our armamentarium of shoulder surgeons, and not to be like,
I think a lot of it's education. You and I have talked about this. People just aren't getting educated on how to do that procedure anymore. They've gone straight from scope augmentation to Latarjet. And if you see a lot of failed Latarjets in young people, you'll think twice about doing it just for any reason versus a select reason. So Paul wanted me to talk secondly about a relatively new technique that we've developed. Alex Lauderman has developed in Europe, about utilizing the long head of the biceps as a non-bony augmentation or dynamic transfer with obviously decreased risk compared to a Latarjet. And we're working on this in the lab as well. So just taking you through some techniques. This is a right shoulder. We're this is through a deltopectoral approach. We're releasing the biceps sheath. We release the biceps tendon from its insertion on the glenoid. This is through a subscapular split, and you can see the labrum and the glenoid inferiorly, obviously retracting your conjoined tendon medially. You're going to end up doing a standard Bankart repair. So these are the anchors that you're going to put on the glenoid rim. And then after detaching your long head biceps tendon, you can repair that to the glenoid rim, recreating a dynamic sling compared to Bristow or Latarjet as well. So this is what it looks like upon completion. You can see the long head is draped over the front of the subscapularis, and then your standard Bankart repair. Lauderman and Pat Denard have developed an arthroscopic technique. The only concerning part for me is they use a pretty large screw, 6.5 screw in the anterior glenoid that you have to be at the exact angle, or you're going to blow through the glenoid. So we're trying to develop some onlay or button type of techniques to help us kind of cinch the long head through a subscap split arthroscopically. So this is a relatively new technique for young, maybe that patient with the poor labral tissue that you don't want to go to an open or to a Latarjet. This may be an option as well.
Do you shorten the biceps up at all, or do you need to shorten it on it?
No, I haven't shortened. Don't shorten it at all. You can really kind of tension with any device how much tension you want to do it at 30-30. Make sure you're not doing it with the arm and internal rotation, and it usually fits pretty well.
And if you're going to onlay it and not engage it into a hole, do you think you need to shorten it or no?
I think you just want to have. That's probably the tough thing right now is what's the exactly right tension, but. It's the same thing for Latarjet. We have different tension on the subscap depending on where you put it. So if I have more laxity, I may put it at the 2 o'clock versus the 4 o'clock position. So it does give me some leeway to kind of how to titrate where I want to put it. So being relatively new, I don't know the exact tension yet.
All sorts of new uses for the long head of the biceps. Maybe it should not just be tossed out. All right. Are you ready for Anoop to take over?
Yep. Let me stop sharing.
Stop share. Yep.
See, share screen. All right. Can everyone see my screen?
Yep. Perfect.
I'd just like to make a comment on Anand's last case, the first one, the open capsular shift. I think Buzz Burkhead gave a really, really great talk several years ago at Academy, how open shoulder surgery was a lost art with all the new trainees. We all have residents and fellows and so forth, and everybody's really quick with the scope. But I think this open capsular shift a la Near, I do it literally 3 to 4 times a year. Similar cases. In this particular one, I think you brought up a really good point that there is one shot for this athlete, and sometimes having an open surgical case discussion with the family, especially the parents, is a little bit more challenging, and they're willing to accept if the scope doesn't work, we have a backup. I think shoulder surgery has always given us that benefit compared to like sports medicine in the knee. The ACL is kind of a one-time go. The revisions tend not to work as well. Fortunately, in the shoulder, we do have some good options, even if the first one doesn't work well. On that note, this was kind of a last minute thing. So I put together a case from some time ago. I'm in the middle of a transition. I'm moving back home to Phoenix, Arizona, and joining Banner University Medical Group. So thank you, Paul, for inviting me. It's good to see you on. And then Joe, we've met a few times in the past. Let's see. So this case is a 30-year-old right-hand dominant male who's had 3 prior surgeries, an arthroscopic Bankart, which failed, followed by an open Bankart, followed by a revision open Bankart. And then, this 30-year-old had recurrent instability after a fall. On his physical exam, the range of motion was symmetric to both sides. Rotator cuff was fine. The axillary nerve had great sensation. There was an EMG done to make sure that the axillary nerve was fine, but he did have, the signs and symptoms of instability. Spline films, shoulder looks like it's a little bit anterior subluxed. You can see some metal anchors that were done before. So this is an older case. The CT scan also demonstrates some bone loss with, close to 40. You could argue up to 50% of that glenoid being involved on the 3D recon. So I think one of the really important things is really how do we determine bone loss? This has always been something challenging for me, whether it's with the CT scan and so forth. And how do you really quantify it? I've still gone back, to the old school method with Gerber. And I think until we have some really sophisticated technology that can accurately quantify it, that has good inter-observer reliability, I think this has really served me well in the past. I had the opportunity to write a little bit with JP, one of my mentors, on iliac crest bone harvesting. And so in this particular case, after 3 particular procedures, we felt that and bone autograft would be the best thing, especially given his age, the extent of bone loss, as well as metal hardware within the glenoid. And so intra-op pictures that we had taken reveal, the glenoid with significant bone loss and, 2 screws placing the iliac crest bone on the anterior aspect of the glenoid, followed with a CT scan and healing. And we reviewed some of the outcomes with this particular procedure with good healing at 4 to 6 months long ago. I think today I would probably consider this. I've become a big fan of the distal tibial allograft. And really similar cases such as this, it's been, proven obviously to be less morbid. You don't have to harvest it. Number 2, that surface really matches the glenoid as Preventure has shown, and his outcomes have been really, really great. I've only adopted this in the last 2 to 3 years, probably do 1, maybe 2 a year, and have had really, really great success with that. Thank you.
I think, Anoop, that's a great case. I think that's a great case, and it's important. We talk about distal tibia a lot more commonly now in the United States, but when we're talking to some of our colleagues overseas who don't readily have that graft available, the distal tibia, the Eden Hybenet's a fantastic. The iliac crest is fantastic. I myself have taken distal clavicle once and found it not to be as consistent. And while I've read about posterior scapular spine, I have not done that as a graft. An and Joe, I don't know if you want to comment on alternate grafts if you're not doing a distal tibia.
I think iliac crest is a great graft. Obviously, there's some morbidity with how you take it, but it's a really great autogenous graft. I've moved with smaller glenoid lesions to arthroscopic distal tibia, and you can use actually a frozen graft. Ivan Wong has a couple large series now that, and he does it extra articulation, extra capsular, and that's worked well. But for these large 30, 40, 50% glenoid, open distal tibia is an excellent option. Joe?
Joe, as you comment, why don't you take over? Anoop, you can stop sharing. Joe, you are the closer.
You see my screen?
Yes.
Not yet. I see you're sharing, but you haven't selected. Maybe you didn't select your your
I
screen
see a
share.
screen. I see it.
Okay, great. Thanks, Paul, for inviting me to do this. Learning a lot. Actually, Anand, you got my curiosity up with that biceps. So now I'm going to start thinking about that more. So thank you. Always a good reason to learn on a Sunday morning. So Paul is all glitz and glamour. So what you see is what you get. And he always looks like this. He's like the mad professor. My disclosures are on the Academy website. So we're going to do a couple quick cases here. This is a 42-year-old fell off his bicycle, ER reduction for shoulder dislocation. Comes in, says he still feels loose despite being reduced in a sling. Normal contour, neurovascularly intact. And these are the MR images he comes in with. You see that inferiorly there, there's some concern about his glenoid and labrum. And then we look at the axial cuts. You can see a Hill-Sachs, and again, as you get more inferiorly there, you can see bony Bankart type injury here, pretty significant in my opinion. And then given the bony involvement, CT scan, axial cuts, as we go more inferiorly, you can see the step off there. So I guess for my colleagues on the panel here, this is a active 42-year-old healthy individual. These are the images you have to work with. He's feeling slippage. What are your thoughts here? Non-operative, operative, and why? I'll start with Paul.
So I think that he's feeling slippage. So I'm likely to tell him to have surgery so I can just restore his anterior buttress. It is a reasonably big piece. I'm not totally sure if it go how inferior it goes. I might look at a sagittal section to know that, but I don't have that. So the debate between an arthroscopic or a subscapular splitting repair to get an adequate repair. I always want to convince myself that I'm going to use a screw or two when I'm fixing these. I find that, it ends up being a smaller, more fragmented piece of bone, and I chicken out of a screw in 75% of the cases. So I would likely do something arthroscopic. I might like to get fancy and do a double row type of repair if I can if the bony piece is adequate for me. And if I felt that I couldn't get an appropriate reduction, I'd have zero hesitation to do a subscap split.
Great. Anand, what would you do?
I agree. It depends on I would probably lean more towards an open, because this looks pretty large. Either with a full subscap takedown, make it anatomic. If it's capable to get a 4.0 screw, I never want to use anything smaller than 4.0 for glenoid fractures. If not, I'll use some type of anchor fixation. I would comment that the double rows, that you have to be cautious. Paper just came out last week. These sutures that you drape over the labrum are essentially articulating with the humeral head. So you have to be cautious with how many and where you put them, and perhaps consider even in some type of long absorbable type of suture or tape to use in that position. But and you don't want to over constrain him. He's 45. He can get stiff pretty quickly.
Great.
Anand, you said nothing other than a 4.0 screw in the glenoid. That strikes me as, as limiting.
Nothing smaller than a 4.0.
Right. So that's pretty big, right? I mean, with these 2.9 screws, how come you feel that way?
Just because everything I've seen fails under 4.0, 3.5, 2.9s, 2.7s. So I think you need at least a 4.0 size screw to get good control of fragments in the glenoid.
I've had some good luck.
3.5 Lauderdale's fail too.
Composite tacks.
Excuse me?
Those long tacks. Biocomposite ones. I've had some good luck with those. So, it's interesting. This one was treated surgically, but you kind of wonder sometimes. I mean, the fragment is large, but he's centered, right? So you can look at his head; he's kind of centered. So if he stabilizes early on, do you think he'd still come out? I don't know, but something to think about. I'm just thinking about that right now.
I'm also worried about just post-traumatic arthritis. I mean, it's right in the center.
Yeah.
Too the step off, not even all just instability conversation, but just
Yeah.
post-traumatic OA.
So,
Joe,
Yeah.
I've seen a bunch of these in 65 and 70-year-olds who've had 1 or 2 or even 3 episodes in their first 3 or 4 days. And initially I operated on them thinking they're having recurrent instability, but I find that older patient group settles down and doesn't have recurrent instability after the first few. Going back to your point, as long as their head's not sitting in the defect and they're centered, they have a chance in the older group.
so we did what you guys alluded to. We did an arthroscopic repair of the bony Bankart and did all the tricks that we talked about to repair this sort of top bottom. This is passed around the fracture, I'm sorry. And pretty good overall reduction stability intra-op, and felt pretty good about it, and was able to return to sport. Now this is a surgery that I think is a nice setup for the next case I'm going to present. This is like the sequel. So this was a 47-year-old female, Foosh, was feeling like she was subluxating, not evalved for a month, then saw an outside orthopedic surgeon, of course, usually, right? So things are going to go bad, right? Outside orthopedic surgeon, that's a disclosure for things went bad. But did not want surgery at that point, but then had persistent slipping, and then subsequently had surgery. So 2-month delay before surgery. Had an arthroscopic Bankart, and these are the pictures from the outside surgeon. Again, this is March. This is what was done. In some ways, similar to what we just saw in the last case. After that, though, she started having feelings of slipping again, but no formal reduction. And then multiple months go by after the procedure. She's taking anti-inflammatories, is having pain at rest. And so the original surgeon schedules her for a ladder J, and she seeks a second opinion. And her range wasn't terrible, and could not. She had some apprehension, and her rotator cuff was intact. She's a recovering alcoholic, but she's been sober 7 years, has depression. And then these are her x-rays. So these are her x-rays when I see her. So thoughts on I'll give you the whole set of images. These are her x-rays. So obviously my curiosity's piqued by her anterior glenoid there. This is the MRI. So this lady had the $1 million workup, x-ray, MRI, and CT with 3D recons. So, to the esteemed panel, I'll start with Anu. What do you think so far here?
I'm a little concerned that her feeling of instability may be just crepitation into the defect. You see patients with OA, biconcavity, feel like their shoulder's dislocating when it's actually just riding on this ridge. So that's a little bit of a concern to me. She's got post-traumatic chondromalacia already. Those are all concerning to me.
So let me continue with that thought process, because I don't know how much time I have, but I don't want to go over. What would you offer her? Would you offer her? So ladder J, it sounds like is a ridiculous idea, right?
Yeah, I'm not going to do anything that tight. She's how old now? She's 49 now.
48, yeah, 49.
48. Yeah. So she's almost 50. She's got post-traumatic OA. I might consider an arthroscopic debridement to take a look in the joint as well. If it's just a solitary defect, which I doubt, but if it's just a solitary defect, maybe I would do some sort of cartilage grafting at the time. If everything else looks clean, take the biceps if it's inflamed, do a release.
Yeah. Anything different?
I agree. I mean, look, you're in trouble here. She's got arthritis. She's not unstable. Joe, your pickup was great. She doesn't need a ladder J.
Any kind of tightening stabilization procedure is going to make her just stiffer.
Yeah. So that's interesting. So, this was back in 2012. So I took her to the OR. And again, We talked about all this stuff. Glenoid reconstruction, not doing that. Shoulder arthroplasty, not doing that. EUA, arthroscopic evaluation with capsular release, cartilage restoration. Ended up doing that. And so this is when the micronized extracellular matrix came out, ECM. And this was actually the first time I had used it. So went in there, examination under anesthesia. She's actually a bit stiff, not unstable, but did appreciate some crepitus. And this is her shoulder after I had kind of released it and looked at it. So decided to do this micronized extracellular matrix. You can see I didn't. It's not a small lesion, but it's somewhat contained. It's central. So did microfracture, dry scope after I did all that, then dry out the shoulder. And it's not a bad technique. I've used it a few times. It's actually done nicely. So inject this material that's mixed with platelet-rich plasma, and then a BioSeal for it placed on it. And she actually has done great. This was 8 years ago. I did recently see her for her other shoulder, and she was still doing pretty well. I mean, not perfect, and definitely developing some further arthrosis, but you know, from the perspective of risk to the patient, exposure, and also risk benefit ratio, I think it's a good thing to think about occasionally. I know Anand's published on this as well, but you can see it fills the defect pretty nicely, and you know, she's now in her, I guess, mid to late 50s. So thought that would be a nice sort of comparison to the previous case I just presented. Thanks.
Thanks,
great.
Joe. That's a great case. All right, guys. Well, we're at 1 hour. I want to thank everyone on the panel, Joe, Anup, Anand, and Hitesh. This has just been another exciting chapter for orthopedic principles and alternate ways to consider shoulder instability. So thank you for your time. Look forward to seeing you again. See you at Shoulder 360. See you at IASES.
Thanks, guys.
Thank you.